Next speaker is Dr. Indu VP. She is a consultant vitreoretinal surgeon in Chaitanya Eye Hospital and Research Center, Research Institute, Kottayam. She is going to talk about intraocular foreign bodies.
Good morning, everyone. So let's go to the topic, intraocular foreign bodies. Intraocular foreign bodies are a major cause of morbidity in the young population. Manual laborers are at very high risk. High velocity projectiles are commonly produced during chiseling, hammering, drilling, gunshot, bomb blast and firecrack injuries. They can lodge in any part of the eye, but most of the intraocular foreign bodies are seen in the posterior segment. That is because they are very sharp and generated at very high speed. They sometimes can ricochet inside the eye, they can bounce inside the eye, producing injuries at multiple sites. Intraocular foreign bodies produce damage due to the mechanical effects, introduction of infection, and due to inflammation, and very rarely sympathetic ophthalmia. Basically, they are divided into two, toxic and inert foreign bodies. Toxic foreign bodies are metallic like iron, steel, copper, and aluminum, and non-metallic like vegetative matter. Inert foreign bodies can be metallic like gold, silver, platinum, and non-metallic like glass, plastic, and rubber. So metallic foreign bodies are the most common one. They are usually sterile because of the heat generated. Iron and copper foreign bodies, if they remain in the eye for a long time, can cause metallosis. Organic foreign bodies are notorious to cause fulminant endophthalmitis. Glass and plastic foreign bodies tend to remain inert and they are well tolerated. They are the most common type of mist foreign bodies. Blast or firearm injuries can cause multiple splinters. They can lodge in different parts of the eye. They are very damaging and very difficult to remove. So when a patient presents to you with a history of something hitting the eye, a detailed history is essential. You have to ask him specifically what he was doing at that time. The mechanism of injury and the nature of the foreign body has to be determined. A visual acuity recording is very important. Examine the adnexa and the lids for external injuries and external foreign bodies. And on slit lamp examination, a thorough examination has to be done, specifically looking at conjunctiva. You have to look for conjunctival lacerations, and pigments under the conjunctiva may indicate a uveal prolapse at the site of entry wound. There can be scleral wounds, there can be corneal penetrating wounds. You have to specifically look for iris transillumination defects and a lens track. All these indicate that something has gone into the eye. The entry wounds in small and sharp foreign bodies like iron chips may be very, very small. It can be smaller than the actual size of the foreign body, so it can be missed very easily. Large irregular projectiles like stone particles produce very large and ragged wounds. They are very difficult to close. If you're suspecting, if you have a high index of suspicion for an intraocular foreign body but you're not seeing anything, always do a gonioscopy to rule out an angled foreign body, because if you have a very large arcus, it can be missed. And always, always, always do a dilated fundus examination. It will help you to identify the lens track and the foreign body in the vitreous or the retina. A photography using a slit lamp or fundus camera helps in documenting the disease and counseling the patient. So here you can see a fundus picture showing a metallic foreign body on the nasal retina. Now coming to investigations, orbital x-rays are becoming obsolete now because of the overall detection rate is less than 40%. They can detect only metallic foreign bodies, and radiolucent objects like glass or wood can be missed on an x-ray. Ultrasound can locate foreign bodies, and the advantage is that it can also help in assessing retinal detachment, vitreous hemorrhage, and endophthalmitis, but has to be avoided in open globe because it causes extrusion of ocular contents. Metal or stone particle appear as hyperechoic structure with an acoustic shadowing, a high spike on A scan, and it persists in low gain. Wooden foreign bodies also appear hyperechoic, but a plastic foreign body can be missed on an ultrasound, especially the spectacle plastic. PVC plastic can have high echogenicity. A glass foreign body was also bound to be missed on ultrasound because it appears only as a reverberation artifact. Air bubbles can also enter the eye during penetrating injuries. They can also be mistaken for foreign bodies. They produce a single-peaked 100% spike on A scan, and the differentiating features are they may be multiple, they move with movement, and they disappear on sequential scans. So CT orbit is considered to be the gold standard for identification of intraocular foreign bodies. They can very accurately detect the number, size, shape, and location of the foreign body. A metallic foreign body has got a high attenuation. Attenuation means it will be whiter in color. Has got a high attenuation with a shadow artifact and a scatter artifact, as you see here. Whereas glass foreign body will have a high attenuation but no artifact around it. A plastic foreign body also looks like this but with a moderate attenuation. But on CT orbits, organic foreign bodies may have a low attenuation. As you can see here, you do not see much of a foreign body there. So CT is not very useful in case of organic foreign bodies, especially wooden foreign bodies. The problem here is that wooden foreign bodies may appear as hypointense or hyperintense depending upon the water content. So green wood is much more difficult to assess on a CT. And the problem with dry wood is that it has got a high air content, so may be mistaken for air bubbles. So CT is not very useful for wooden foreign bodies, and in such cases you have to go for an MRI orbit. MRI can detect organic and glass objects with greater sensitivity, but MRI is contraindicated when you do not know what is the nature of the foreign body or if you're suspecting metallic foreign bodies, because a magnetic field can cause change in the position of foreign bodies and more damage. A UBM or an anterior segment OCT can be done if you're suspecting an ankle foreign body. The advantage of UBM is that you can screen behind the iris and the ciliary body also, whereas in anterior segment OCT, the foreign bodies behind the iris may be missed. ERG can be used for prognostication of metallosis like sidrosis and chalcosis. Now coming to management. So you know the goal of the surgery is is required, or the removal of the foreign body is needed. So the goal of surgery is to prevent further damage and to restore the ocular anatomy. Functional restoration of visual gain is only secondary, which has to be explained to the patient. And the first step is the primary repair of the ocular cords. A meticulous repair of the corneal and the scleral wounds is extremely important, and the anterior chamber has to be formed. If the eye of P is in the anterior chamber on the angle, it can be removed by viscoexpression, by using a magnet if it is magnetic, or with forceps. And make sure that you do not remove it through the direct entry wound. A separate incision has to be made. And if as lens management has already been done with. For intraocular foreign bodies, these foreign bodies which are impacted in the crystalline lens, the problem here is that if the foreign body remains in the lens for quite a long time, the lens can become cataractous. It may become mature. In such cases, the foreign body may not be seen and the entry wound may be very, very small. So in such cases, there is a chance that you can miss the intralenticular foreign bodies. If you're suspecting intralenticular foreign bodies, avoid a hydrodissection because a PC rent can cause the foreign body to fall posteriorly. So this is a patient who was a stone breaker. He came with an history of injury 5 weeks before. He presented with a mature cataract. And so a routine cataract surgery was being done here. So you can see a small incision cataract surgery is done. Now managed like a normal cataract. But after cortical aspiration, you find something shining at the posterior capsule. This is actually a metallic foreign body which was missed and was diagnosed intraoperatively because there was no other external injury. Posterior segment foreign bodies are routinely managed with a 3-port vitrectomy. If the lens is cataractous, the lensectomy or cataract surgery can be done. So this is a young patient with a metallic foreign body presented 1 week after an injury. So you can see a vitrectomy is being done. You can see an encapsulated foreign body near the ora serrata. So with a cutter, I'm slowly disengaging it. It jumped onto the posterior pole, however, no damage was done. And because it was very small, one of the ports was enlarged. And with an intraocular forceps, the foreign body is gently picked up without causing any damage, and it is slowly removed through the port. So in this patient, we were able to salvage the lens, and we were even able to leave the patient without any tamponade, and the patient recovered well with a 6/6 vision. However, in very severe cases like this, so you see a very large penetrating corneal wound which has been repaired, lens is cataractous, vitrectomy is being done. So you see a large foreign body that is impacted on the retina. So with the forceps, it is being pulled out. So you see it's almost like a stab wound on the retina. And when it is pulled up, you see how big it is. And so because it was so big, it could not be removed through the pars plana. So it's brought into the anterior chamber. A limbal incision is made, and it is brought out through the limbal incision. So the retina was almost non-salvageable. So, and no tamponade was done because there was a risk of posterior leak of oil. So prophylactic intravitreal antibiotics should be considered in all these cases to reduce the risk of endophthalmitis. All these patients have got a very long-term risk of corneal scarring, cataract, glaucoma, and retinal detachment. And always there is a risk of sympathetic ophthalmia in 0.5 to 2% of cases. A very short note about cirrhosis. Cirrhosis happens due to chronic iron foreign bodies. So you can have a heterochromia of iris. You can have a brownish pigmentation of the cornea, the iris, and the anterior lens capsule, anterior capsular cataracts, and also an retinitis pigmentosa like changes on the retina. And in chalcosis, it produces greenish discoloration of the cornea, producing a Kieser-Fleischer ring, sunflower cataracts, and if the copper content is very high, it can result in endophthalmitis. So the take-home message is that the details about the mode of injury has to be elicited from the patient. You should have a high index of suspicion. Always look for an entry wound. It may be missed. It may be very small. Always do a dilated fundus examination. Only then you can see the lens track and a posterior IOP. And timely intervention is extremely essential. Thank you.